This is month 9 of doing these. Seems like we just started these, so I appreciate you all showing up. We go over a case from the clinic every month dealing with some sort of fitness athlete, somebody crossfitting, Olympic weightlifting, powerlifting, sometimes running, but I try not to see those patients because I hate running. So we have a person here for that sees those people whenever we can. So this week we put the body chart out early in the ICE students page. So hopefully you had a chance to look at it last weekend of this week. And you've come with some brainstorm ideas because I'm going to flip it all to you a little bit this week. We'll go over it a little bit, but instead of just kind of talking at you all, I want to make it a little bit more discussion based. So that being said, we will fire up presentation. Oh, lost my window. There we go. So everyone should be seeing this now. So this patient's name is SB. She's a 42-year-old female. She's doing CrossFit for a long time, at least 5+ years. She's a mom of 3. She works full-time at the school, and then she also does some house cleaning on nights and weekends, shorter kind of hour-long bouts on weeknights, and then cleaning rich people's giant mansions on the weekend, 2, 4, 6, sometimes 8-hour bouts of cleaning bigger houses on the weekend. So this is her body chart. So hopefully you had a chance to look at that. If not, we'll go over it a little bit. So her main complaint is patella dislocation, non-traumatic. Happened about a week ago prior to her initial evaluation. 10 out of 10 pain, lasted quite a long time. Calming down over the 7 days leading up to her eval. Now is 0 out of 10 at rest, but still feels swollen, bruised, really stiff. Also reporting some right hip weakness and fatigue, kind of pointing to hip flexor area, lateral hip. Feeling that leg buckles sometimes, especially with stuff like step ups, saying that she can't really step up beyond the height of a normal house step now, which is a new issue for her because this is somebody that's in the gym doing box jumps and stuff like that. So definitely a new symptom to report. Reporting aggravating factors for the knee of kneeling on it. So she does a lot of kneeling, cleaning, obviously, going up and down stairs. It aggravates about after 4 hours up to that 10 out of 10. And it takes quite a while, usually the rest of the day, evening to calm back down. So moderate to high severity and irritability. And then her hip bugs her anytime she's using that leg. So stairs, trying to be in the gym, just any sort of use with that hip brings on that feeling of hip fatigue, like it's going to buckle. Asking her easing factors, putting rock tape on her left knee makes it feel more stable. She's also been wearing a fixed knee brace that has the patella exposed and just kind of increases the time before she feels her symptoms. She's able to get most of her cleaning done before the pain makes her stop. And then just resting the hip is all she's found that gets rid of that hip fatigue, burning feeling. So some goals: she'd like to return to CrossFit. Concurrently with this injury, or I guess a little bit before it, she had a COVID-19 infection. So about 3 weeks before this knee issue, she was out with COVID. And then COVID infection segued into this knee hip issue. And she hasn't been back to the gym since. So she's been almost completely sedentary for about a month. Obviously wants to be able to perform her job, ADLs, including cleaning. And she would like her knee to not dislocate again, which I think is a fair goal. So some hypotheses here: patellofemoral pain syndrome, lumbar radic is on my radar. And then I put NSED, which is just what I write for not strong enough disease, when I think somebody has just been not working out enough and I think could benefit from some focus strengthening that would probably clear up a lot of their problems. So seeing this body chart, where would you all, we'll go through any relevant history. I think I said all this in words. Yep. And then no issues. No issues with sleep, nutrition, or stress, aside from obviously kind of being stressed out about the injury, but nothing relevant. She works with the gym nutritionist. She sleeps pretty well, no complaints there. So hearing all that information, what would you all and where would you all want to take your examination based on what we think is going on? Some knee pain, knee pain, some right hip weakness, complaints of burning around the hip. Where would you take the exam? $10,000 bonus points to the first person to answer.
Well, I think since you thought it was lumbar or dick, you can always start centrally at the low back and then work your way down the leg.
Oh, speaking to my heart, that's exactly what we did. I want to rule out that lumbar spine first, and make sure nothing in the hip and nothing in the knee is coming from the back. You want to, sorry, 1 second, everybody. Get lost. So active and passive range of motion in all planes of motion, including quadrants. Nothing checked out, couldn't reproduce knee pain, couldn't reproduce hip weakness with anything active, passive range of motion. Obviously hearing burning, hearing new onset of random muscular weakness. We want to do some neurodynamic testing. So we laid her down and she did have a positive straight leg raise, 47 degrees, quite stiff. And then she had exact reproduction of the right hip symptoms and also brought on some right foot numbness and tingling that she's not complained about prior to me doing the straight leg raise on her. So lumbar exam was very revealing for some of her symptoms. Nothing shook out in the knee though. So lumbar is definitely on the treatment list. Left knee exam, looking here, hearing complaints of stiffness, swelling, measuring her range of motion. Extension was fine. But missing quite a bit of knee flexion compared to the other legs. So she's missing about 13 degrees on the painful leg. And then just trying a couple different things. I tried Thessaly's and some other kind of meniscal type special tests. Nothing shook out there to reproduce her pain. So I asked her just to stand on that leg and just got a feeling for left single leg weight bearing. She was able to stand for 30 seconds, but she was really apprehensive. She actually wanted hand touch assist to not fall over. So whether that's fear avoidance or actual that much legitimate weakness, who's to say, but definitely something revealing there. And then screening the hip on the right side, I found extension and abduction very, very weak. She could not give me any resistance at all, and it actually reproduced her left knee pain. So some severe right hip weakness, some lumbar involvement, and a stiff knee, all kind of on board here in the exam. So treatment, got into her quads with some dry needling, kind of longer duration, using the low high frequency sweep here, taking her up to 620, just trying to get a lot of muscular activation into that left knee. And this actually improved her left knee flexion about 10 degrees. So just firing her knee, getting that knee pumping for about 20 minutes, getting some blood flowing in there seemed to be quite beneficial. Okay, so 30-ish, 40-ish minutes into the session, you have 20 or maybe 30 minutes left for loading. Where would you take this patient loading wise? Where would you take her, knowing we probably want to get something objective on the books that we can measure against to make sure we're getting stronger as visits go on, and then kind of addressing all the different stuff that she has going on. Throw out some ideas here for me. Not Chelsea.
Maybe some hip thrusts.
Ooh, you guys are on it tonight. I like it. That's exactly what we did. We went to the gym. My goal was to find something a little bit heavier than this, like a 10 or an 8 rep max. But just the way it shook out, I ended up having her do build. And then we got quite deep in the weeds on volume. So I just had her do a AMRAP set of her last set of a barbell hip thrust. So she's able to show me 145 pounds for 12 rep max. And that should say predicted 1 rep max of 200 pounds, not 9 pounds. So that's a typo. So going off a theoretical 1 rep max of 200 pounds, which all things considered for somebody who's been very active for a long time is quite weak. Your hip thrust should be heavier than your deadlift, and your deadlift should be very heavy if you've been training with weights for a while. I would expect closer, somewhere above 300 pounds, knowing that she has a 200, mid 200s deadlift. So a little bit weaker than I would have expected. But we got a good objective measure that we can program off of for future visits, which was the whole goal. And then focused on some quad strengthening. We did some slant board goblet squats at a really aggressive tempo, a 5-second eccentric and a 5-second concentric every rep. So a lot of time under tension, getting well above the 220 seconds we like to see for any sort of tendinopathy time under tension, which really made her legs feel like jello in a productive manner. And then trying to give her hip and knee strengthening at home. Luckily, this is a person that has been doing CrossFit for a while. Kind of as people tend to pick up equipment here and there for home. So she's got quite a bit of equipment at home. So her HEP was a little bit more advanced than most. So wall sitting, able to give her that same thing we did in session, giving her some heel elevated goblet squats, trying to keep that same tempo, and then giving her some single leg kettlebell RDLs to work her hip and hamstring. Fortunately, doesn't really have a way to really heavily load the glutes and the hip itself like we can with the hip thrust at home. But nonetheless, this is better than doing nothing. So that was her first visit. Follow-up visits coming in, visit 2. Frequency here with this patient is about twice a week. Didn't have any pain or dislocation since her last visit. Has always been going to work and still doing her cleaning. So nothing has come down workload wise, which is a good sign that she's kind of able to tolerate that stuff better. Maintained all the knee flexion that we gained last session. Improved her straight leg raise. We didn't really address this directly with manual or exercise aside from the single leg RDLs. So I'm thinking that is probably to blame for a little bit of improvement in those neurodynamics there. She was able to stop wearing her fixed knee brace. And every now and again, when she felt her knee was not as stable as it could be, she put some rock tape on, especially for those longer cleaning sessions. And just reporting that her right hip, more so than her left leg, was very, very sore after PT. Manual therapy, same thing, dry needling in the quad complex as our starter. And wanting to breathe is what she asked. I want to open my lungs up. So we dialed that up for her. Giving her some low box step ups here, 12-inch, so a little bit higher than a house step. I believe we tried 14 or 16 inches here, and it was too high and actually gave her a little bit of knee pain. So we backed down to a 12-inch box. She was able to tolerate the lunges without knee pain, which was great. So we did some walking lunges. Minute 3, I had her, she asked to breathe. So minute 3, I had her do max cals on the assault bike and just tracked her power output as an asterisk in case we come back and repeat this. And then minute 4, after having her hammer the bike, I gave her a whole minute of rest. On the 12-inch box, not reporting any issues with step ups or lunges, but did report a continued kind of right hip muscular burn. Coming back in, visit 3, still no issues in the knee. Knee flexion improved a little bit, about 2 degrees. Just hearing reports of right hip burning, right hip stiffness, I decided to investigate right hip flexion. And it was quite gummed up, 112 degrees. So not as much as we like to see, especially if we're thinking about full depth squatting and deadlifting and that sort of stuff in the gym. Straight leg raise was about the same. Still rock taping is needed. Right hip still very sore with her HEP. So we needled her quad complex, and we also needled her right iliacus and psoas, and a little bit of her right external oblique. So kind of the right lateral and anterior hip chain. Same parameters, the sweeping stem, and then took her out into the gym. Wanting to open up that hip a little bit more, we did some deficit lunges. So each foot up on a plate, with her a 25-pound plate, so about a 2-inch deficit. So just working through an increased range of motion with that lunge. Very unsteady here, no pain, but very unsteady, only able to lunge 5-pound dumbbells. And then a little bit of conditioning, some unilateral deadlifts and carries, and some cows on the C2 bike, made it feel like a mountain bike. Pull the seat off, turn the damper to 10, and only let her ride it while she's standing. That's going to feel a lot like driving uphill on a mountain bike. Very, very quad heavy movement. Remeasuring hip flexion at the end of the session, gained about 16 degrees of hip flexion, which I'll attribute probably to the lunges. So added some hip flexor work to her HEP with a heavy TheraBand, some psoas marches down on the ground. Visit 4, still no issues with the knee. Left knee flexion is now equal to right. Maintained some hip flexion from the last visit, 125 degrees. No change in the straight leg raise. And then still rock taping is as needed, but not on a daily basis. Knee looks good now. So going just right into the right hip with some needles, and then programming some working sets of hip thrusts, and now kind of chasing that right hip. So we know her max already, so now we can program. So I wanted her to do 5x5 at about 80%. So for her, that's about 160 pounds. And then another little short AMRAP for some conditioning, some cows on the rower, some step ups. She was able to go up to a 16-inch box this visit without knee pain, and then really kind of still working that lateral hip, holding a side plank while doing a banded clamshell, working a lot of the right hip musculature there, doing 8 per side. Really big jump in hip flexion here, 138 degrees after PT. So quite a big jump, really opening up that hip with a lot of hip focused work. Revising her HEP this visit, increasing the vigor a little bit, adding about 10 seconds to her wall sits, keeping the RDLs, keeping the psoas march, and then adding in the banded side plank and clamshell that was done in the conditioning piece this visit, and then addressing that straight leg raise a little bit, even though she's never complained about anything distal to the hip, still trying to address it. So having her do a supine nerve slider with a band, so laying on her back, going straight up with a straight leg, kind of pumping the ankle on and off into dorsiflexion, plantar flexion for a minute, and then going out into abduction, external rotation, pumping that ankle, and then crossing the midline into adduction, internal rotation, pumping the ankle. When she crossed the midline into adduction, internal rotation, is when she had a reproduction of symptoms in the hip, and also some foot numbness and tingling. So definitely a nerve component to that. So I had her doing that every day after this visit, and just seeing what changes with that straight leg raise and kind of that neurodynamic sensitivity to the next visit. So coming back in, this was this past Friday, so the end of last week. Able to go snowboarding over the weekend. Right hip and left knee were sore, but nothing that lasted. Coming back to CrossFit class now with just some modifications for the workouts, and just noting some left medial elbow pain with shoulder pressing and pulling. So kind of completely unrelated to the stuff we've been working on. Left knee maintaining that 145 degrees of knee bend. Right hip flexion improved from the last visit, so she maintained some gains there. And then a nice improvement in her straight leg raise as well, getting to 65 degrees. And then completely change of pace for treatment here, looking at the, this should say the left shoulder, sorry, looking at left shoulder range of motion, and just finding she's missing about 20 degrees of abduction on her left shoulder. So kind of makes sense. Usually the elbow is not to blame for a lot of movements. It's usually an issue up in the shoulder, and that seems to be the case here. So I'm liking the way the hip's going. I'm liking the way the neurodynamics are going, and I like the way the left knee is going. So this session is kind of a combo of addressing her shoulder, and then also kind of continuing to finish the drill on her hip and knee. So needling here, anterior posterior delt, getting into her subscap a little bit, and then also picking up the distal tricep as well, just trying to open up that overhead abduction range of motion. And then loading in the gym, doing some half kneeling landmines. She was able to press 60 pounds for 4 sets of 8 per side. Noting left shoulder was weaker, but not having any elbow pain. And then switching gears back to her hip and knee with her Therex dosed out as 4 rounds for time. So doing some rear foot elevated split squats with dumbbells, some C2 bike, and some lateral box step overs. No issues here with the step overs, no knee pain. Not really noting any hip burning, fatigued challenged, but no burning. So that was a nice improvement as well. And then remeasuring her shoulder range of motion, 180 degrees after dry needling. So fully perfect overhead range of motion like we like to see. So it just seems like something was gummed up a little bit in the shoulder complex. Reinforcing that at home with some sideline shoulder abduction with a 2-pound dumbbell, just to kind of reinforce and try to maintain as much of that 180-degree abduction as much as possible. So I would love to report the rest of this case to you, but with COVID taking back off, her school went virtual and she hasn't been able to come back in since. She's missed her last 2 visits. So visit 6 looks like this, but she's on my schedule for this Friday. So it'll be interesting to see if we've maintained knee and hip gains, as well as what that shoulder has been looking like in CrossFit and with the stuff that we've added to her HEP. So a little bit shorter report tonight than I'd like, but very happy with how quickly this patient has progressed. This has only been about 3 weeks of physical therapy. So we seem to have addressed the knee pain, the knee stiffness, the right hip, the neurodynamics of the right lower extremity are all on the right track. So it'll all be interesting to see where she ends up on that stuff when she comes back in on Friday. Pearls here, make sure you rule everything in and out. This is somebody that had a lot of stuff going on. If you had not gotten into the back and just chased the knee, you would have not reproduced the hip symptoms through the back and not been looking at neurodynamics, which could have affected how quickly this patient could have progressed. And then this is a patient that prefers chiropractic treatment because it's quick, it's 15 minutes, and it usually fixes what's wrong in that visit. So this is somebody that's seen me before, but that requires a lot of education. That actually fixing this stuff long-term takes a little bit of time. And then this is a CrossFitter. The biggest thing you can do for somebody that's active, whether they're CrossFitter or not, is keep them doing whatever they're doing. Even if it means they're doing it in PT and they're killing themselves on the assault bike in PT, just making sure that you keep that intensity where they want it. That really helps with buy-in. So happy to take any questions anybody has. We'll probably revisit this next month and look at the complete plan of care, what happened with the last couple of visits. Okay, hearing none, seeing none, we'll wrap it there. I will post this recording. What's up, Mark? It's nice to see your face.
What's going on, Alan?
I will
Thanks,
post.
man.
I will post this recording in the event for this month in the iStudents page. So if you jumped in late, I saw some of you cutting in and out. If you couldn't quite catch the whole thing, I'll throw this video in there and you can rewatch it at your leisure. And then next month we'll tackle the end of this case. So appreciate you all being here, spending your Wednesday evening here. Hope you learned something, and we'll see you all next month.